has the CDCP actually improved access to dental care? Welcome back to Dental Talk. Today, we're exploring the CDCP 1 year after its launch. Joining me is Paul Allison, professor in the Faculty of Dental Medicine and Oral Health Sciences at McGill University in Montreal. Welcome, Professor Allison.
Hi, thank you very much for having me, Gary.
Let's get right into it. The CDCP's first year approved more than 3.4 million applications and has delivered care to 1.7 million people, with almost every dentist and hygienist in Canada now seeing CDCP patients. What does that tell us about the program's early impact?
Well, I think the impact appears to be very strong. There was clearly a very strong need for this innovation in dental care. The care that was in existence before CDCP was good for those who could get to it, but there were lots of people who simply couldn't get to the dentist. They couldn't afford the dentist, they couldn't get physically to the dentist, et cetera, et cetera. So the fact that this has reduced financial barriers for so many people is fantastic news. And the fact that so many people have signed up as patients, and indeed I was looking at the data earlier today, it's actually quite a lot higher than the latest figures. Something like 4.5 million have been signed on, and over 2.5 million have had some form of care already. So this speaks to the fact that there's a very large number of people in Canada who need dental care and want to get to dental care, and that this new CDCP is helping.
So clearly, with 4.5 million more adults expected to join, one of the biggest successes, obviously, is access to care. What, in your experience, have been the key learnings so far?
Well, I would say it's difficult to say what the key learnings are because we don't know the data yet about what form of care has been provided. We don't know the data about who's going. So there's lots of things we still don't know. We just know the very high-level raw numbers. So again, I would simply say that the only conclusion I can draw at the moment is there's an enormous need out there, and this is helping to fulfill it in terms of people signing up and apparently getting at least some form of care.
And how has there's been a phased rollout over the year. Has that helped or hurt the program?
I think it's probably helped. It was an extremely ambitious rollout by the government. I think presumably for political reasons, they wanted it rolled out as quickly as possible. When I was in conversations with Health Canada staff behind the scenes, they were saying that it was a remarkably speedy rollout, and normally a program of this size would have taken much longer. But for a number of reasons, they wanted it rolling out fast. So I think the fact that they did it stage by stage with the different groups within the population, certainly it helped Health Canada staff, but I would imagine it also is helpful for dentists and dental hygienists to not be all of a sudden bombarded with this very, very large number of additional people. So I imagine it has been somewhat helpful for them as well. So overall, I would imagine it was a helpful way to try and do this.
You mentioned the lack of data so far, and some experts argue that the CDCP lacks transparent data on outcomes and care patterns. How can Canada build on the early enrollment success to create evidence-based improvements for both patients and providers?
Well, I think it's really important that Health Canada, Statistics Canada, the federal government use the data that's available, both from the administrative data from paying dentists and dental hygienists to provide that care. So we should have some idea of how many people, what sort of treatments, what different groups of people are going. But then on the other hand, that administrative and payment information is good for what service has been delivered, but we don't know what the outcomes are. So I think it's really important as well for the government to be doing surveys, both questionnaire surveys, asking people in the population and asking people who've used that service about their outcomes, whether their needs have been served and fulfilled or not. And also to do clinical measures. You may have heard of the Canadian Health Measures Survey, which was recently completed. It took 2 years to measure approximately 7,000 Canadians across the country, including their oral health status, including clinical measures, as well as a lot of other health measures, physical and general health measures. Those data, they finished collecting in December 2024. Apparently, it's run by Statistics Canada, and apparently the preliminary reports are going to come out in early 2026. So we should have good baseline data, because that was done at almost exactly the same time period as CDCP was rolling out. So what would ideally happen is Statistics Canada would do a similar study in 3, 4, 5 years' time to see how things have happened in terms of the overall health of Canadians since CDCP.
Do you think, in your opinion, with the access to care now, that the health system already is overburdened, and a lot of that is due to dental emergencies? Do you think in the healthcare industry and patients visiting the emergency departments of hospitals, do you see that decreasing and less burden on the healthcare system in general?
Well, that's one of the outcomes one would hope, because as we understand very well, visiting the emergency room with a dental emergency is often not a very successful thing to do in terms of the success of the outcome. I mean, you may get some pain dealt with, unless you're lucky enough to go to a hospital with a dental unit and you can be seen by a dentist. With all respect to the emergency room staff, most of them wouldn't know what to do, so you end up being prescribed with a painkiller or an antibiotic. And of course, we know prescriptions for dental problems of antibiotics is a major problem in terms of contributions to antimicrobial resistance. So I think, going to that and getting care that's probably inappropriate is not good. And so hopefully far more people will be going to see the dentist, whether it's for the urgent care or hopefully actually getting some form of care which will prevent that emergency occurring in the first place.
So with 98% of dentists now participating in the CDCP, how can practices better serve and incorporate this new population of patients into their schedules? Patients who may have gone years without care.
They understand very well the needs of many of those patients is going to be pretty extensive. I would say that it's really important to try to understand the extensive risk status for these sorts of patients, high risk status, and all the different social determinants of health and disease that these people have, and consider those in generating a treatment plan. Consider their needs as a patient, and the possibility and probability of having probably to adapt the treatment plan to something that's going to work better for somebody who's not seen a dentist for many years and has many needs. So I think it's going to have to be an adapted form of care. I do think that begins to speak, however, as well to other system level changes, which I strongly believe have to happen. I think dentists and dental hygienists in private offices are doing a fantastic job, doing as good a job as they can under those circumstances. But if there's a very large proportion of people coming in now with very much higher needs, I think it speaks to the fact that we need to be thinking about alternative models, which are not just based on paying per treatment. In other words, having community clinics with community healthcare centers, with the GP, with the other social services, so patients that go into those services can get dental care because the office is right next door, and that those people may be paid in some other way, whether that be through salary or through some form of capitation system or whatever, recognizing that they've got very high levels of needs, and it'll be more complicated to care for them. And those people are not only high risk for dental problems, they're high risk for a whole range of other health problems as well. So they need a complex care and a system where you get paid by the filling you do, or the crown you do, or the whatever, is limited in what it can do for those complicated scenarios. So I do think it speaks to us needing to think about other models of healthcare, And I would say, the government did recognize this in the sense that they set up the Oral Health Access Fund. And so there are projects that I believe are going to be funded going forward to try and pilot different models of care as well.
With all eligible groups now able to book care, how does Canada's dental system compare with models in the UK, Germany, or Australia? And what can we learn from them, and what might they learn from us?
Yeah, it's very difficult to make these sorts of comparisons. I think we all like to try and do that, to try and say, oh, is this system working better than the other system? They're all different. And I think all health systems, whether dental or general healthcare, are struggling with the massive load of chronic health problems, whether it's chronic health problems that are dental decay and gum disease, or heart disease, diabetes, et cetera, et cetera. They're all struggling. We're all trying to find the best way. In my opinion, I think we should be using a system which is a universal system, not for everything, but we can have a good level of basic care within that system. And then the more sophisticated, more complex care can be part of the private insurance system. That's the model they have in Germany. In the UK, it's a sort of hybrid where some people have to make a fairly significant contribution. In Australia, it's very similar to here, and quite frankly, it's a bit of a mess, like it was in Canada before this, where in each state, in Australia or province in this country, it was different. Federal government, provincial government, it was all over the place and different. So it's really complicated for patients and providers in Australia, just like it was, and in some levels continues to be here.
Well, you touched on private insurance, and about 2/3 of Canadians have employer-sponsored dental plans, and there's concern the CDCP might prompt employers to cancel or reduce them. How do we design public coverage to complement rather than replace existing benefits?
Well, as I said, I think that, thinking of different models. So the model where you've got universal care, and then the private insurance systems are there for those more complex forms of care is a very good way. That's the model that works in Germany, and it works pretty well, actually. So I think but that's a different model to what we're doing in Canada at the moment. That's an interesting situation in terms of the insurance. It's the same as well in some of the provinces. In Quebec, where I work, there's a universal system of dental care for kids until their 10th birthday. Exactly what's going to happen in the future. Is it going to be the Quebec government that pays for those kids' dental care? Is it going to be the federal system? It's a complicated scenario.
You have used national oral health surveys to document inequalities. Which data points will show whether the CDCP is narrowing gaps, and what would success look like for the vulnerable populations?
I think on the first level, you want to see that there's more equity in access to dental care. In other words, are more people going to see the dentist, and there's less of a difference between people in terms of earning levels or the other typical social indicators like job status, education status, etc. All those typical socioeconomic status that are very well documented to show differences. If we can reduce those inequities, and classically, public systems, that's what they do. They're very good at reducing those inequities. So we want to see access to and using care. And then after that, getting back to the point I was making earlier, we want to have measures of health of people, whether those are self-report measures, like saying, is there fewer people in pain? Are there fewer people having problems chewing food? Those sorts of things, self-report indicators, which are really important. But then on the other hand, we need clinical indicators. So we need to be able to look in people's mouths and say, oh, these people have got more treated disease and less untreated disease. So that's a really important indicator. What's the level of untreated disease? There's always going to be some, and there was always far more in the poorer parts and more marginalized parts of the community. Hopefully the CDCP is going to reduce the levels of untreated disease in the community. So that's one of the things we will be looking at, hopefully, in the future.
Yeah, it's very interesting, the link between oral health and general health, and see, if the oral health obviously improves among those that haven't got it, whether the general health will also improve in those particular populations as well.
Absolutely, because we understand that that there are so many associations, not necessarily causal links, but certainly associations between the health of our mouth and the health of the rest of our body. So hopefully, if we're able to help those with more treatment and less untreated conditions, then that's going to improve overall health as well.
And certainly tax the healthcare system a lot less as well.
Hopefully.
Well, Professor Allison, thank you very much for such a thoughtful discussion. The CDCP has brought millions into care, but as we've heard, there's still some kinks to work out.
Sure, absolutely there are, certainly.
We'll continue to track the latest in oral health policy and innovation right here on Dental Talk. We'll see you next time.